You would think that as we develop new drugs, we'd get better at making sure that they don't damage the lungs, and that's probably the case. But the newer so-called targeted agents, the EGFR tyrosine kinase inhibitors, that's epidermal growth factor receptor inhibitors, the one that we use in the United States, erlotinib or Tarceva, there is an incidence of Tarceva-induced pneumonias, so Tarceva-induced pneumonitis. And that occurs in about 1% of patients treated in the United States. Another drug, gefitinib or Iressa, which is not used in the United States but used in Europe and Japan, you can see up to 2% of patients who have this interstitial lung disease and hemorrhage. And it's usually seen within the first 3 months of treatment. And I have seen a fair bit of this. Bevacizumab, another new drug, monoclonal antibody that binds the receptor in the lung. It's used for non-small cell, non-squamous lung cancer. It can cause hemoptysis or coughing up blood for the squamous histologies. That's why we don't use it with squamous cell carcinoma, though that recommendation might be changing soon. I mentioned in many of the previous slides that steroids are commonly used to treat chemotherapy-induced pneumonitis. What I'm going to tell you now is that even though we use them, there are really no controlled trials, meaning that when we see this happen, we think it's inflammatory and we treat with the steroids, but there's no trial that says that if we didn't give steroids to half our patients and we did give it to half our patients, what would be the better outcome. One of the things that's important, though, is steroids dampen the immune system, and that's what we want when we're having some of these inflammatory reactions. But you got to make sure that the patients don't have infections, because when you have an infection, you want your immune system to work really well. And so oftentimes that's why doctors will maybe want to do a bronchoscopy. That's where we take a look in the lung and do a wash in the area of the X-ray changes and send that for culture. So we don't want to commit someone to steroids to treat an inflammatory drug-induced pneumonia if they in fact have a bacterial pneumonia. So sometimes your doctor will ask you to do that bronchoscopy to make sure there's no infection before we give you steroids. If we're going to treat patients, we generally give them a prednisone and 60 milligrams a day for 2 to 4 weeks, and then slowly take it away once the patient gets better. So now I want to switch gears from drug-induced pneumonitis to radiation therapy-induced pneumonia or pneumonitis. And this occurs usually between 1 and 3 months after radiation, but can occur up to 6 months after radiation. So it's not as if you have to have it immediately, but you can have this reaction weeks to months after your last radiation dose. Radiation fibrosis, or a really bad scarring process, usually occurs within 6 to 24 months. So that's a bit more long-term damage and usually stabilizes after 24 months. And you don't have to see radiation fibrosis or scarring. You don't have to have had radiation pneumonitis to see the radiation fibrosis or scarring. That can occur independently of having the pneumonia first. So about 7% of patients, which seems like a high number, I will tell you many of those are not severe cases and many just are X-ray changes without too much symptoms at all, can occur after receiving chest radiotherapy. The lung injury increases with the volume of tissue irradiated and the dose. So the higher the dose, the higher the volume, meaning if you have a larger tumor and they have to get a fairly sizable portion of the lung within the radiation port, the more likely you are to have radiation-induced lung disease. There are different fractions, and I think anyone who's been through radiation knows this. You get, for example, 10 treatments in 10 days. Some people go for 30 treatments in 30 days, depending on your cancer and the need for radiation, are associated with a lower risk. So if you can give smaller fractions at different times during the day, they're associated with lower risks of pneumonitis than single large fractions. The hallmarks of having this radiation pneumonitis are a fever, generally a low-grade fever, and a dry cough. Again, they don't produce much phlegm, and shortness of breath. And when you see this, it's pretty classic. They'll tell you they finished their radiation 3 or 4 weeks ago, 6 weeks ago, 8 weeks ago, and gee, doc, I'm having a cough, I'm not bringing any phlegm up, I feel like I might have a low-grade fever, and boy, am I short of breath. 2 weeks ago, I was able to walk a football field, and now I barely can make it half a football field. We also look at their chest imaging, which sometimes can be absolutely classic, and I'm going to show you a few pictures of that for radiation changes. And then again, we want to make sure that other processes aren't going on. We want to make sure the patient doesn't have infection or heart failure or a drug-induced problem in that population. So we want to make sure it's not something else before we ascribe it to radiation pneumonitis. In the early stages, what happens is you actually get some injury to the small blood vessels, and you get some fluid leaking out into the lungs. That causes these membranes. I'm not going to go into very great detail, but it causes inflammation and scarring of the membrane of the lining of the lung cells. And then you can get problems with buildup of a more scarring-like process. And all those fancy words you see on this slide are basically a way of saying a scarring process becomes apparent. If the radiation damage is really mild, it can actually recede on its own, but it gets severe, again, 6 to 9 months after the radiation, a chronic phase or a scarring phase develops. If you give a fairly sizable dose of radiation therapy, you will see changes in up to 40% of people on X-ray. Now remember, the tumor is also in there as well, and hopefully what that's done is wipe out the tumor but leave a little bit of a scar behind. And what you see down here, the dose, I don't expect you to remember the name, but the dose of 30 gray, that's just a fancy way of telling people how much total dose of radiation you've received. You seldom see any problems. In the 30 to 40, you can see it. Greater than 40, you almost always see some kind of scarring process. And I'll tell you, the average lung cancer patient for an average tumor, and you know there's a lot of variation here, receives around 70 gray, which is to say that, again, most of my patients who get radiation will have some scarring process. This is the chest X-ray on the left of a classic radiation finding. What I want to show you on the right is they made a pattern on this patient for where they wanted the radiation to go. They wanted to get the center of the chest where the lymph glands are and the tumor, which was right over here. So now if you superimpose that pattern onto what it looked like after their radiation, you see what's called a straight line sign, which means that in this patient, you almost never see this with anything else. Everything else respects the lobes of the lung. But when you get radiation, you see this square or straight line sign, which is actually the pattern of the block of radiation that was put through the patient's chest. Now, this patient may not have any symptoms at all. This might just be the scarring process that occurs after radiation treatments. So serial X-rays in these people can be helpful. Sometimes your doctor will want to make sure that he looks to see how this radiation changes are progressing. Some of the chronic changes, the one I'd like to tell you about is once a scarring process starts, you can get a loss of lung volume. It can pull the lung, that lung will scar up so that it kind of squeezes together, and I'll show you an example of that. You actually lose some lung space. Now again, hopefully underneath all that, the cancer's been cured. And this is a case of that. Here's a normal left lung, and here's the heart border along here. What you see is in the right lung, there's very little air in the right lung in the bottom, and up top, what you see is a loss of lung volume from the scarring process that occurs. Now again, you could be completely asymptomatic, not have any symptoms, be able to walk 2 flights of stairs and play golf, if that's what you like to do. But sometimes this can cause a loss of lung tissue, and in certain cases can cause shortness of breath. Sometimes the radiation scarring process, the radiation pneumonia process, causes changes in the X-ray outside of where they were radiated. And I'll show you that. But when that happens, it's generally an allergic reaction. So you get the radiation therapy to one area of the lung, but it causes a diffuse inflammatory process in both lungs. So we're using newer techniques to radiate smaller cancers. One of those radiation techniques you may be hearing lots more about in the future is called stereotactic body radiotherapy, or SBRT. Some people call it the CyberKnife, some people call it tomotherapy. It's all a fancy way of saying that what we can do is, instead of placing all of the radiation on block from front of the patient's chest to the back, we can actually bring the radiation in from different angles and have it converge on the tumor. So single radiation coming in from a bunch of different angles, one single beam of radiation from many angles that converge on a tumor, which is here in the arrow. What that does is it causes all the radiation to meet in one place, but you don't get all the radiation in the normal portions of the lung. So each of the portions of the regular lung receive very little dose. The dose then ends up just at the tumor where you want it. And you can see after radiation, there's just this very focal area of radiation changes. And this is perfectly agreeable. It's a nice scar that you should see after radiation therapy. So with some of the newer techniques that we have, stereotactic radiation therapy, very, very high-profile technique that's being used in the better cancer centers throughout the United States and the world, I think what you're going to be seeing is maybe less radiation pneumonitis in the future. Not everybody's tumor is eligible for that, but certainly when you have a tumor eligible for that, it's a really, really nice way to go. So these are focal areas. That's a fancy way of saying scarring. And it doesn't correspond to the planned target volume, and it differs from radiation pneumonitis after conventional radiation therapy, because conventional will be a big block area, and with this type of radiation pneumonitis, it's a small, tightly bound area. But some of these scarring processes from the treatment of lung cancer mean that we do have to deal with these problems for a longer term, which is great by me. I'd rather have them alive with a few problems than not alive at all. But what you should be aware of is that the longer patients live with lung cancer and are treated for lung cancer, the lot more likely we are to see some of these chronic changes on X-ray. So the treatment for radiation-induced pneumonitis, again, the experts recommend prednisone at 60 milligrams a day for 2 weeks with a tapering dose over the next 3 to 12 weeks. There's no controlled trials telling me that that's the absolute dose we should use, but we certainly do use that. I will tell you in my practice, I try to get patients better with the prednisone, and then as quickly as I can, I get to the lowest dose possible so that I don't have to deal with the side effects, or the patients don't have to deal with the side effects of prednisone. The guidelines for the taper aren't clearly defined, but if symptoms recur, sometimes you have to put patients back on steroids, certainly at the lowest possible dose. There's a drug called pentoxifylline, which is actually, believe it or not, used for patients with hardening of the arteries. And there is some evidence that using it reduces radiation pneumonitis. There's not yet enough evidence in larger trials to warrant its use, but I just put it out there as something that you may hear about in the future. Just to summarize, about 2% of lung cancer patients have complications not from the lung cancer, but from the medicines and the radiation we use to treat lung cancer. You really have to have a high index of suspicion, both on the patient side to say, hey doc, this just doesn't feel right. I got this drug 4 hours ago and this is what's happening to me. And also on the doctor's side, we have to be very good detectives and try to pick up on what our patients are telling us, what the imaging shows us, and just not write it off to cancer or an infection. Finally, radiation pneumonitis can be both localized to the area of radiation or diffuse in both lungs. Treatment is used with corticosteroids, but sometimes the damage can be permanent.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.